Hey friends, we're back. We are going to carry on. We're going to talk about some stroke stuff. Again, we're still talking neuro here. So if you want, you can look at what Drennan was talking about here. Again, just working through a bit of a case with us not being in the same class. I don't know that there's too much importance in that right now. But feel free to pause the video, go back and think of some questions you're going to ask about stroke and try and see what you know about stroke even before we dive into this. So if you want some statistics on stroke, here are some stroke statistics for Canada. You should know that most of our strokes are ischemic in nature, meaning that a clot has broken off and formed, blocking off a blood vessel, and 20% now we're talking about some sort of bleed that's in the brain. And so with that, when I talked in the last slide about FAST as our stroke assessment, that T is for time. You can see a word in the bottom right here that he's written out, and that's penumbra, or if you really want to pronounce it P or not, but penumbra. So that is what we are trying to minimize. Again, it's kind of like that whole argument about, should we be moving patients with C-spine injuries? Well, we have to do some movements. We want to minimize those movements. We want to make sure that they're important movements. We're not just rolling them around just for fun. But the damage has already been done. So whether there's a clot or a bleed, the damage has been done. We're trying to prevent that secondary damage from getting bigger. So with C-spine, we don't want to be rolling patients unnecessarily. We're going to put a collar on them and all that kind of stuff to try and mimic their head movements until they can be assessed to say, okay, yeah, you're actually okay, or no, you need some surgery and a halo or something like that, and let the bones heal up so we don't make a bigger injury. Well, with stroke, there's not too much we can do right now except time. So we want to get these patients to the hospital as quick as possible. So it is quite common that you'll see stroke centers pop up. Again, I work in Simcoe. RVH is my closest stroke center. It's the only stroke center in Simcoe County. If you do work in the south of Simcoe County, it's not uncommon to go to Cortellucci, I believe, is the southern, the next most southern stroke center for us. Excuse me. So we have bypass protocols that allow us to, if the patient meets certain criteria and we deem that they're having a stroke, or at least it appears they're having a stroke, we can bypass our closest hospital and get them to these stroke centers so that they can be assessed and hopefully, given the right medication, clot buster, or be assessed for surgery, those kinds of things, so that they can get to the proper care they need. So that T is for time. We need to be moving quick but appropriately with these patients so that we can prevent that penumbra from getting bigger. The longer they are without oxygenated blood or blood flow, the bigger the problem. So when we talk about strokes, what we're really talking about is cerebrovascular accidents. So you'll hear people talking about CVA. There is a problem with the blood supply, whether it's completely blocked or severely reduced, or is it there's an actual hemorrhage that's going on. We're losing 2 million neurons a minute, so time is brain. There's that T word again, T for time. Here's the difference, right? You could have a little bit of a leak that is now causing the brain to not be able to meet its metabolic demands because it doesn't have the blood supply it needs, in a hemorrhage. Or there's a clot that's formed. There's risk factors for this: atherosclerosis, eating a fatty diet, all those kinds of things. They all can contribute to this. You're hardening of the blood vessels, and you get clot formation, you get narrowing of the arteries, and all these kinds of things. So there is a little bit of control over how much we can prevent strokes, but at the same time, there's a lot of genetic predisposition, stuff that we can't really control either. So anyway, take it for what it is. However, it's why are we calling it a CVA versus stroke? Well, the stroke is the actual medical diagnosis that this is a stroke, but there are some other things that might mimic it, and so we'll call it a CVA until proven otherwise. Things like a transient ischemic attack, people call that a mini stroke. These are when patients present with stroke-like symptoms, but then they resolve on their own, typically within an hour. But so to us, it might look like it's a stroke, but it wasn't a stroke. It was a TIA. So we can't differentiate between them. So you're better off calling it a CVA or suspected CVA until proven otherwise. Again, most people don't really bust your chops over this in the field, but if we're going to be academics about it, that can be an example of why we call it a CVA as opposed to a TIA or a stroke, because we don't know. What you should know is that if you have a TIA, you are at a much higher risk of having a stroke in the next coming days. So it's not one of those things. Again, we need to be able to come to our patients with some information to try and convince them to go to the hospital if we think that that's best for them. And they can't make those decisions if they're uninformed. So we have to do the best we can to inform them. So a little bit of statistics probably actually helps us quite a bit. So I encourage you to try and stay current on what these stats are, because they will change over time. So, what are we talking about here? They like to classically talk about the right side of your brain being responsible for certain things, and the left side of your brain being responsible for other things. And so with that, you can kind of, if someone's having a stroke on the left side of the brain, you might see issues in their right hand, because you get that contralateral control. They might have a hard time with written language. Likewise, if someone's having a stroke on the right side of their brain, they might have problems with spatial orientation, or if they were super musical, they might not be able to play music like they used to. Pianists and all this kind of stuff. So if you've never seen a diagram of the brain, this is what we're talking about here. Excuse me. I might be coming down with a cold after that Remembrance Day parade yesterday in the rain. So here's a general breakdown of our brains. We have the frontal lobe on the left side here in that light blue. We have the primary motor cortex right behind that, which separated from the primary somatosensory cortex. So one controls movement, one controls our sensation. They're separated by the central sulcus. We have the parietal lobe behind that, the occipital lobe, which is responsible for vision, the cerebellum underneath that, which is responsible for motor executions, and then we have the spinal cord below that. Again, that's all that information coming from the brain, the central processing unit, if you will, getting sent down through the body to be able to tell our body to move where we need to be able to bring in that sensory information, saying, that stove's too hot, all this kind of stuff. And we also have the temporal lobe for hearing and some taste and all that kind of stuff. So when we're talking about blood supply to the brain is a thirsty organ. It likes to have lots of blood. It needs to have lots of oxygen to it. I forget all the stats on this, but I thought it's something like the brain consumes 20% of the oxygen that we breathe, or something like that. Don't quote me on that. But there's lots of blood supply. There are loops, or at least a loop in there, the loop of Willis. Anyway, just to ensure that the brain keeps as much blood supply to it as possible. So if there is a block in one artery, you kind of have not collaterals form, but you have other pathways that'll bring blood to that area and hopefully try and reduce some of that hypoxia or ischemia that might go on. So when we're talking about strokes here, aren't we? Yes, we are. So some risk factors for stroke. Hypertension. Again, we have a little bit of control over that. What are you eating? Are you exercising regularly? Are you taking care of yourself? Are you a smoker? Do you partake in some pathomimetics on a regular basis? Are you diabetic? The older you get, the more your arteries start to harden. The more they, at the same time, you get weak spots forming, so you're at more risk of a bleed, that kind of thing. Have you had previous strokes before? AFib is a big one. When I was going through university, AFib was said to be the number one risk factor for strokes. Again, with AFib, your atria aren't pumping effectively, so with that you get blood pooling. Anytime we have blood pooling, we're promoting clot formation. If we then come in and have a big contraction, or I come in and electrocardiovert somebody who's an AFib, for example, and they get that massive contraction and that kicks a clot out, that clot can go and lodge itself in the brain. So certainly some things that are at higher risk for strokes. Some we control, some we can't, or at least have some influence on. So differential diagnosis, if you're thinking strokes, think about these. Again, not an all-inclusive list, but do they have a tumor? They may know about it, they may not know about it. This might be the first thing that gets them in to get diagnosed with that tumor. Maybe there's infection. Maybe hypoglycemia is a big one that we need to be on the lookout for, because we can look for that fairly easily pre-hospital and treat it easily and well pre-hospitally. You will look less educated, let's use that term here. You will look less educated if you come into the hospital claiming that someone's having a CVA, just for the nurse to reach over and do a quick blood sugar test, which takes all of 6 seconds, just to find out that they're hypoglycemic. And then next you know, they're starting the line and giving them D10. So think about these things. Try and cross off the low-lying fruit. Again, we're limited what assessments we can do in the field. If you bring in somebody who's got facial droop, they're not hypoglycemic, no risk, no recent infection, all this kind of stuff, and it turns out that now this is a new infection that's gone on, and everything presents like stroke, no one's gonna fault you for that, because they probably have to, okay, maybe they have a fever, who knows, but that doesn't necessarily, it's not, the biggest, it's not, a guarantee just because they have a fever that they have a new infection causing stroke-like symptoms. They could be concurrent, all these kinds of things, right? But if you come in with somebody who you truly think is stroking out, and they have to do blood work and they have to do imaging and all these kinds of things to rule out stroke, no one's going to make fun of you, because you don't have that blood work and that imaging with you in the field, right? They had to go to extra things that you don't have. That's why you went to the hospitals, to get those resources. Excuse me. So stroke is becoming kind of a cool thing. There's different ways of trying to deal with stroke, getting people informed about life decisions they can make, how to assess to look for a stroke. I can't tell you how many times we go to patients and they're like, oh, so when do these symptoms start? Last night before bed. Okay, well, that was like 8 hours ago. Why are you just calling now? Oh, well, they didn't get any better. All right, let's talk about time as brain, all these kinds of things. It's to the point now where like you can even go to, with telestroke, you could be way up north and they'll just, at a medical center that has no doctor, they can call down to a stroke doctor and start doing assessments and getting medications on board and all this kind of stuff. So, ooh, look at that. There's FAST. So, generally speaking, people don't know that someone's having a stroke. There's poor recognition for it. So we're trying to come up with these easy mnemonics to help people remember what to look for. So, FAST is an example of that. So what do we do as paramedics? We are necessary to recognize these strokes. Sounds stupid, but again, some of these patients don't realize they're having stroke, and it's for us to show up and say, I feel like, anecdotally speaking, I go to more people who say they're having a stroke, and we get there and it's very obvious that they're not having a stroke, but that's okay. Maybe it's something else that we can help them out in other ways, and that's fine. But identification is important. Again, especially if they call quickly, that starts the clock for us to get there and check them out. We have limits as to how soon we can get them to the hospital for proper stroke care. That means that we're not going to take them to the hospital. It does not mean that we're not going to take them to the hospital if they are outside of our windows, but we have to be able to get them to the stroke center for TPA, so tissue plasminogen activator. That's the current drug that we're using for stroke treatment right now. It's a clot buster. But in order for a patient to get it, they have to have imaging, because it would be super detrimental to give a clot buster to a patient who's having a hemorrhagic stroke. Likewise, I guess the research is showing that for endovascular therapy, they can go in and literally suck up the clot and try and pull it out if they're having a ischemic stroke. And when we talked about the Lamb score, this is what we're talking about, is the higher the Lamb score, the bigger the stroke area affected is. So potentially, bigger clot in a bigger artery, affecting more area. They may be candidates for endovascular therapy, where they, like I said, go up and vacuum that clot out, kind of looking like, I guess, what you might see on that slide where we showed the blood clot for the pulmonary embolism. But it's not effective for patients after 6 hours. So we have tight timelines that we have to get there. So with that, we have to be moving quick. This says ideally we're off scene in under 20 minutes, and Ian Drennan's corrected that to say less than 10. Like, these are very quick, easy assessments, 9 times out of 10 for us. We can walk in, and again, the more practice up and focused you are, and you can work well with your partner and all this, and multitasking, it's totally different than what you're seeing right now in first semester lab. I totally understand that, but it's not hard to be off scene with, as long as there's no extrication issues and the patient's not combative or anything like that. It's not super hard to be off scene in under 10 minutes. So think about that. We walk in, quick assessments, quick blood sugar. You can be doing vitals in the back of the truck, all these kinds of things. Yeah, we don't want to just, you have facial droop, we're going to hospital. It still has to be in the context of stroke. We still have to rule out other things, but as you get faster with this stuff, you will be able to move a little bit faster through these and get your scene times down. So we're looking for less than 6 hours from the clear onset of symptoms. So again, it's super frustrating when you go to someone, they're like, oh yeah, it's 9 a.m. I went to go wake up my husband for breakfast. He looked like he was having a stroke last night, but I thought it would just resolve, so I let him go to bed. God, that's frustrating because we've just wasted so much of this time. There's that LAM score. I talked about it in an earlier video, so feel free to pause this and refresh the memory on that. Again, just to try and bring in a piece of more current research. Like I said, TPA is the only drug that we have right now. When I was doing my master's, the lab behind me was the only... it was a lab that was working on pre-hospital stroke identification and treatment, and so it was super cool. I wish I was a paramedic at the time, but they were involved. They've made it the furthest that any drug since TPA, and I think TPA came out in like the 60s or 70s or something. It's been a long time. That's still our gold standard. But like I said, you need to have imaging before you give it to them. But this lab behind me was working on a drug that medics could give pre-hospitally. So this lab was going into ambulances in Toronto, Vancouver, and I want to say like LA or Seattle or something like that, and actually installing fridges because their drug had to be refrigerated. So the company, like, yes, it was a lab, yes, it was tied in with Toronto Western Hospital and U of T and all this kind of stuff, but the individual researcher had made his own company called No. So the second no is nitrous oxide, and so this was a nitrous oxide inhibitor, I believe, which helps stop that secondary shed, that penumbra, from getting bigger. Then it was a pre-hospital drug that they were trying to get marketed so that people could give this drug in the pre-hospital setting. Think about how much time this would save. Yeah, if you live in Toronto, you can get to a stroke center pretty quick. For us in Simcoe County, I think majority of Simcoe County can be reached by RVH, or can get to RVH, within like an hour. Not too bad. However, you go further north, and now all of a sudden you're up in Abomatong, and it's a fly-in, fly-out only community, unless it's winter and there's an ice road, which is going to take you way longer than flying plane. But now you got to dispatch a plane or a helicopter, get up there, get the patient, get back down. Or we could send them to the health clinic that's up there, and they can get this drug in the meantime, and then still have resources coming to transport them, but get that drug on board. Anyway, so it's been a minute since I've looked at them. I should try and figure out where they're at with that. Last I heard was that the studies had stopped, which is super disheartening, but hopefully they can figure something out and keep going with that, because that would be huge. And especially to have a Canadian research team lead that, like, you're talking like Nobel Prize worthy, at least in my opinion, and many other people I've spoken to. Now, the downside of that was the researcher was a dick, so he wasn't the most fun to listen to. I remember going to one of his lectures that he gave, and he was just condescending as all could be. And this is even, I think I was wanting to be a medic at this point, but before I'd even started PCP school. And he's like, yeah, so, if my lab's successful, paramedics will be able to do more than just drive the ambulance. And, this guy's arrogance killed me. But still, super cool. So if you're interested in looking something else up, look up no nitrous oxide. No. All right. So when we're talking about stroke, we're looking for extremity weakness. Assess one leg at a time. We're going to have the patient, hopefully in a sitting or laying down position, ask them if they can lift one leg off the bed. See if they can hold it there for 10 seconds. If they can't do that, see if you lifted it up, can they then hold it there for 10 seconds? Can they do the same with their arms, holding them straight in front of them? Again, if they can't, see if you bring their arms out for them. Do they just rapidly fall to the ground, or are they able to hold them out for 10 seconds or so? Look for any of these, any drift that's happening in either of these. We're going to assess their speech. Again, our stroke protocol, I'm going to see if I can pull it up quickly while I'm talking here, but our stroke protocol says that any unilateral arm or leg weakness, any speech, what are the word, speech deficits, all right, maybe let's go with medical references here. Sorry, it's been a minute since I've looked at this. I just want to give you guys the exact wording if we can. Right there. Field trauma trio, paramedic stroke. So, unilateral arm or leg weakness or drift, slurred speech or inappropriate words or mute, or unilateral facial droop. If a patient has one of those three things in the context of stroke, we can bypass our closest facility and bring them to a stroke center. So we're going to ask them things like, can you say a simple sentence? Repeat after me. It's a beautiful day outside. Most people, most grown adults have no issue saying something like that. But patients with strokes might have a hard time getting those words out. They might be slurring their words completely. They might not be able to speak at all. So those are, some common things we might do. We might also hold out a pen or a book and say, what is this object, and just see if they can name it. So we're assessing their speech. We're going to ask if they have any numbness and tingling. So, light touch on their finger. Which finger am I touching? Can you feel when I'm doing that? If I'm not touching, do you have a sensation there? Is that normal for you? These kinds of things. But make sure you have them close their eyes. That way they can't cheat by that visual input. We're going to be looking for facial droop. We've already talked about this. Can they smile? Can they grimace and show their teeth? Is this symmetrical? Does one side move and one side doesn't? Are they able to, lift their eyebrows? One side goes up or both sides go up, those kinds of things. So just because a patient has that doesn't necessarily mean that we throw them in the back of the truck and we start hauling off to the hospital, lights and sirens as quick as we can, bypassing our closest to go to our stroke center. There are some contraindications. So if the patient, and this is one that grills me a little bit, because again, a lot of medics commonly don't seem to understand this, and they just read, oh, it's a CTAS 1, that means I can't go. Not true. It's CTAS 1 and or uncorrected ABC problem. So a patient could still be a CTAS 1, but if you don't have any airway, breathing, or circulation problems, you are able to bypass on this. Medics get that wrong all the time. Drives me nuts. So usually what they'll do is they'll just downgrade the CTAS and say they're a CTAS 2. Well, that's not what we're doing. Let's just be like, I don't know, it's this big thing about people always wanting to everyone's always afraid to call patients a CTAS 1. It is what it is. Just do what your job is and get these patients where they got to go. And if they're a CTAS 1, they are a CTAS 1. If they have an uncorrected ABC issue, bring them to your local hospital, because again, that's just the base hospital physician saying that this patient is too high risk for us to bypass. They need their closest facility, be stabilized, and then be shipped out. The problem with that is now that patient's going into the closest hospital, which isn't a stroke center, and they're going to be triage, put in the system, they have to be assessed, then you have to book another unit, and so it slows the process down drastically, but at the same time, it's one of those risk-benefit things. Did the symptoms resolve prior to the paramedic arrival? Again, that's indicative of a TIA, so if you get there and they still have symptoms, and then they resolve after you have departed the scene, you're on your way to the hospital, that's okay. Keep on going to your destination, be in the stroke center. But if you get there and they're like, oh yeah, I had all these symptoms, and you don't actually get to lay eyes on them, they don't want you bypassing. If they're not hypoglycemic, if they are hypoglycemic, that is something that we can try and fix on scene, so they don't want us. And hypoglycemia commonly mimics stroke-like symptoms, so that's something that they would like us to correct before we bypass. We have to ask if there's a seizure at the onset, figure out their GCS. So again, this doesn't just go away. If their GCS is less than 10, this patient's probably too unstable. They want us to bring us to the closest facility as opposed to bypassing. Are they a terminally ill or palliative care patient? So again, sometimes a bit different conversations to have with these patients, but again, just ask simply. Sometimes you'll even get cues about this without asking. So you might ask, hey, where's the patient's health card? And they come back and say, oh, I think it's in here. And they hand you this big yellow folder. That's called an EDITH. EDITH is an acronym for expected death in the home. Those patients, if you have an EDITH, you are palliative or terminally ill. So, you can kind of just confirm with them and make sure the patient, the family understands what's going on. But again, it's one of those things where, at least my understanding is, these are resource demanding. There's enough patients needing these resources, so we aren't going to do these procedures for patients who are end of life. And there's also a limit as to how far you can bypass. Like I said, in Simcoe County, our whole county can reach a stroke center within 1 hour. That being said, if you're in the back 40 needing extrication and we got to call in our TAC team and a gator and all this kind of stuff, and it's going to take us an hour to get you to the bush, and then you're on the outskirts and it's going to take us an hour to get you to the hospital from there, now we're going to our closest facility, right? So that being said, these directives are typically written for Ontario-wide type stuff. So this is just saying that if you need to call an airplane because you're up in the Arctic Circle, you're probably not going to be bypassing. So what can we do to treat these patients? Rapid assessment and transport is important. BGT, I think they're going for blood glucose here. Blood glucose test, maybe. I don't know what the T is, and that's okay. But that is, a lot of medics will even start bypassing different vital assessments and just go straight to a blood sugar. I'm not recommending you do that in lab, but that is something you do see commonly in the field. Give them oxygen if needed. This is an old school thing that's kind of funny. When I was going through school, if anybody had stroke-like symptoms, if anyone had MI-like symptoms, they got 100% oxygen. Now we're only treating them with oxygen if they have SATs less than 94 or less than 88, if they are COPD patients. Hook up to a cardiac monitor. Again, maybe there's something there that's giving you some hints. So what's going on? Are you IV certified? You likely should be initiating an IV in these patients if they are stroke-like, because again, maybe they deteriorate. Again, it's easier to get an IV in someone who has a blood pressure than someone who bottoms out, those kinds of things, but we're not going to give any medications via IV. And so in saying that, turn up your volumes here, people. If you're going to do an IV for a stroke patient, and I just told you that there's no medications that we're going to give these stroke patients that's going to fix the stroke, sure, we can give normal saline and try and correct some hypotension. There are other things we can do to try and correct hypotension before we can start the IV. But is there a point to starting these IVs on scene? This drives me nuts. I hate when my partners try and start IVs on stroke patients on scene. Or, oh, we'll get in the back of the truck, we'll start an IV. No, we'll get in the back of the truck. I'm going to put the truck in drive and you're going to do the IV on the road. Or we're not doing the IV, or you're driving and I'm in the back doing the IV, because we're not wasting time to do an IV on somebody that we're not going to give a drug that's going to, make a huge outcome here. So please, please, please do not start IVs on scene just because you think it's sexy to start IVs. Years ago, there was Send Paramedics movement, and there was an article that was written about Windsor paramedics complaining how Windsor Fire got sent to, I shouldn't say Windsor paramedics, but it was in the context of Windsor paramedics, Windsor Fire. So fire got sent for a stroke patient, and whoever wrote the article said fire got there, they sent 4 people. And don't get me wrong, I understand that, there are certain calls that we are throwing money at to send firefighters to, and I played for both teams, but we're sending firefighters to, and they have, and I'm not trying to downplay what they do, they have an important job, but minimal effect. And you could use that money to put more paramedics on the road and actually have more effect. So I get that argument. But this writer, in my mind, shot himself in the foot. He's like, yeah, so the paramedics show up and the firefighters, there's 4 of them standing there, and one guy's just holding the patient's hand, doing absolutely nothing. Our paramedics showed up, they put 2 large bore IVs, one in each AC, initiated fluid resuscitation, and transported the patient to the hospital. Or I don't even think they said initiated fluid resuscitation, but 2 large bore IVs and transported the patient to the hospital. Cool. You just admitted to them starting an IV on scene for absolutely... Now, I wasn't there. Maybe this patient is markedly hypotensive and we have to do a little bit of resuscitation before we even start transporting. Who knows what's going on. But the way it was written, they just sold out the medics saying that they did an IV on scene, and probably should have been done on route, right? Like, we're not giving medications through that IV, so why are you sitting on scene and wasting that precious time? Time is brain. Can't stress that enough. Anyway, so we get into the hospital. Depending on what kind of treatment they're going for, if they go for EVT or endovascular thrombectomy, they're going to go up there, kind of use that vacuum, suck out that clot. Again, it has a time window of 6 hours. I don't know why. Sometimes I go to 24 hours. That's out of my scope. I just do my LAM score. I assess for stroke, and I get them to the hospital. So again, that's for those large vessel occlusions. Otherwise, as long as it's not a hemorrhagic stroke, we can give them some thrombolytics or fibrinolytics. There's that TPA. It's going to dissolve that clot, hopefully restore that blood flow and get some oxygen going back to the brain. Hemorrhagic strokes, on the other hand, that you need some steel. That's a surgery-based candidate usually. I think sometimes it might occlude itself. So again, don't quote me in this stuff. But the treatment for this is blood pressure management, spontaneous reabsorption. So sometimes they'll just keep monitoring these patients and seeing if they are getting better. Maybe they can get in there, like I said, some steel, some surgery, try and fix the clot. But there's usually not too much that we can do at this point, which is unfortunate, but it's just the way it is. I think I've touched on this quickly before when we were talking about thoracic aortic aneurysm and stuff like that. So in aneurysm, you have a ballooning of the vessel wall. So we talked about quickly how there's 3 different layers of the blood vessel walls, and if you're in the venous system versus the arterial system, the intima, the media, and the adventitia are different thicknesses, different strengths, all that kind of stuff. But when you have an aneurysm, you have a weakening of that blood vessel wall, allowing the ballooning to happen here. And so again, something that docs like to monitor. Sometimes they might put a wire graft over it to try and strengthen it, prevent it from popping. Sometimes these start leaking and get problematic, but when they get super problematic is when they burst. Because now you have a big bleed happening, and it's essentially a hemorrhage. Well, if it's up in the brain, you have a hemorrhagic stroke going on. Again, now you're increasing that. Well, you're having a problem with blood pressure. Blood delivery, getting oxygen to the tissues that need it, removing byproducts of metabolism, that kind of thing. But you could also be having increased intracranial pressure, where that blood's pooling in the brain, pushing on that brain. That brain's going to herniate. The only spot it can go is pushing down on that brainstem and causing a herniation. So intracerebral bleed, again, 2 words that are super important in there, or 2, I guess a prefix there is intra, meaning within, cerebral, meaning brain. So this is within the brain itself. It's not on top of the brain. It's within the brain tissue. Excuse me. Mortality depends on where it is. It can occur anywhere in the brain, and so this is what that might look like on a CT scan. So you can see on the right side here that big, lighter whitish kind of area, lighter gray area. If you look on the left side, you can see 2 halves of the ventricle that you can't see on the right side. You can see that the structures are shifting. There's pressure being put on that left side because all that blood pooling up on the right side. We sit here and when we bring these patients in, it's not uncommon for us to watch a CT, depending on who your partner is and how busy the service is, all that kind of thing. But usually CT techs will let us, or imaging techs will let us watch these kind of things, and it's pretty cool, at least in my opinion. But that's what we're looking for. So if you see something like that, that's indicative of a hemorrhagic stroke. That's a big problem. So how might these patients present? Headaches, visual disturbances, nausea and vomiting, super common. Sometimes they seize. They might have altered level of consciousness. But a big one that you might want to put an asterisk next to, it is in red writing here, is Cushing's triad. So there's that widening pulse pressure. Their blood pressure starts to increase, and that widening pulse pressure. So pulse pressure is the difference between your diastolic and your systolic blood pressure. They become bradycardic and have irregular respirations. And again, I believe that's because that herniation that's going to happen on that brainstem. The brainstem holds is the center for those primitive functions such as the heart rate control, the breathing control. And so if we are squeezing on that, it's going to just cause some detrimental effects that present like that. So subarachnoid, if you're not up on your cerebral anatomy, we are talking below the arachnoid membrane. So you have the meninges, you have the arachnoid membrane, and then you have the brain itself. So we're below that, but we're not intracerebral yet. So so we're between. We're still above the surface of the brain, I should say. This is commonly caused by burst aneurysm or trauma. So these. Sometimes they'll talk about a thunderclap, so it's a super severe, rapid onset of the headache. It's the worst headache they've ever had. Sometimes they seize, and you might see other signs of increased intracranial pressure. So here's our treatment for these patients. What can we do for them? Oxygen is needed, maintain ABCs, maybe an IV again en route, because what are you going to do for these patients otherwise, unless they start seizing? But you might see some arrhythmias when they get to the hospital. Again, blood pressure control, maybe look at giving some clotting promoters, look at some surgery and some supportive care, but it might also just be trying to teach these patients a new way of life and helping them with rehab so they can adapt to having one side weaknesses or things like that. Anyway, that's the end of this video.